First of all, I am grateful that you are here, especially that in Florida, in contrast to New York State, you have a wonderful weather, sunny, and you are here inside, so I just want to express my appreciation. I will share with you another aspect of my work, which has been in relation to divorce. And I had a sabbatical by now 7 years ago, and in the course of my sabbatical year, I was involved in learning about divorce and mediation, and I found then in a very concentrated manner that children who have been in these situations with divorce were frequently accused by one parent, usually the mother, about her concern that the child had been sexually abused by the father, the non-custodial parent, and that in order to clarify these issues, they were submitted to a specialized interview for abused children. This interview in all the states, and this happens also in Europe, requires that the child says in words who was it, where it was, and if possible, when it was. This is not easy for a child because, as you know, the majority of sexual abuse occurs within the family, intrafamilial, and the child usually has an intense, albeit ambivalent, but intense relationship to that parent, and many times the children are directly instructed to keep this secret. And then I thought for myself that maybe we could add to the very complicated assessment, add and hopefully maybe some even replace this verbal information into other languages. And this is the background of this research. Dr. Lina Normandin, who is professor of psychology in the University of Laval in Quebec, Canada, has been the main implementer of this research, and the children that I will be talking about come from court-referred children. They come via the courts, and then they are being seen in a comprehensive psychological, medical study, and at this moment there is a follow-up of these children. They have around 250 children. So we will see the results on the first 30 children. I will come back then to the introductory comments. One, it is difficult to determine with any accuracy whether a young child has been sexually abused, and young child may be either under 5 or children who are in this elementary school but don't dare to speak and have to keep this secret. The assessment is complicated, especially for young children. And we thought that play could be an avenue to go into this arena, because play is a language, it's a way of communication for the child. We have found that children with different psychological disturbances play in different forms, and one of my ambitions is to introduce this into the diagnostic categories, because play can serve as diagnosis. A depressed child plays differently than a gender identity disorder child, and here you have children with depression, have difficulties in initiating play. Children with gender identity disorders play to reenact compulsively roles of the opposite sex. Children with attention deficit disorder tend to go from one play activity to another in fast succession with minimal fantasy play. Autistic children play at a more sensory motor level, characteristically use toy for their physical properties, hard, soft, rather than for their functions. Lenorter has been the pioneer in the area of identifying characteristics in the play of traumatized children. Lenorter, as for those of you who may not know her, she is a child psychiatrist, a psychoanalytically oriented child psychiatrist. And she described in these children who have been traumatized, and trauma have been, for the first children that she described were the children of Chowchilla, which was a bus that was kidnapped, put into a hole. The children were kept there for 26 hours. They were not hurt, except that they did not know when or whether they would come back to their homes. So this is a measure of trauma. And she found in these children that the play that they engaged in had the compulsive repetitiveness. It was over and over the child plays the same thing. This is characteristic of children who have been traumatized. The second component was that there was an unconscious link to the traumatic event. So something of what the child play had to do with the actual experience. Literalness. What I have, this quality, I have myself called it documentary, in the sense that it's concrete, literal, but also it has the relationship to the event, the same quality that a documentary film goes to a regular film. The documentary film is also a construction of what happened, but it's closer to the events or what is being shown than a regular film. And this is typical of the play that we have observed. Failure to relieve anxiety. This play, in contrast to the functions of play, which is to give mastery and resolve anxiety and metabolize, as it were, drives, aggressive or libidinal drives. This is a play that is a play that is repetitive and it fails to relieve anxiety. And it's like a vicious cycle. The child attempts to play to relieve anxiety because that's the function of normal play, but in trying to do that, as it repeats the trauma, re-traumatizes again, and it's a vicious cycle. Then we have it can start at different periods, usually between 3 weeks or up to 3 months after the traumatic event. This is interesting because children who play with this traumatized child are contagious and continue playing like the children of Chowchilla. They were playing with other kids who also played a lot with tracks that went under sand and hidden objects. So this is another characteristic. Danger themes are played. Doodling habits that interfere with performance, kind of scribbling things. Repeated drawing of trauma-related subjects. So the same repetition compulsive is transferred to the drawing arena. The play of sexually abused children should also have a characteristic profile. That was our assumptions. And then what we did was to really try to define what is normal play in the consulting room. At least in my training experience, nobody told me what was normal play in the consulting room. So please be critical of what you hear, but this is our operational definition. The play is an activity that the child initiates spontaneously and develops into a narrative that comes to a natural ending. The child appears satisfied with a feeling of accomplishment. This is satiation, play satiation in terms of Erikson. This is the regular consulting room. Nothing special in it, the one that we have, all of us. The child in this normal play is absorbed during the play activity and shows typically positive affects. The child may include the adult in his play in a variety of ways so that an exchange between child and adult is apparent. The child invites you to play, you are assigned a role, you play the role, so there is a cooperative quality about the play. His play will be appropriate for his age and gender. The child creates the play narrative moment by moment. Very important. A play is a creative act, so that the child doesn't know. It's like a painter. They have a general idea, but each detail, some things occur, so it's creative. So the child creates the play narrative moment by moment. I am mentioning all these characteristics because all of these characteristics will be not there in our group of children sexually abused. The child switches in a flexible way the roles and activities of the characters of the play. So there is a narrative and development of characters. I missed the last one. Affects are, this is pathognomonic. Affects are typically pleasurable, and that's why so many of us like to do play therapy, because when we have a child involved and absorbed in the play, it gives you a smile, and it's just very nice. So a child who is playing like this either doesn't need therapy or has changed enough to say that the child is getting there. So it's a way of assessing change of the child within the sessions. Okay. The purposes of play, I don't know, this will be like ABC for the child people, but how many adult people are here? People who, well, I will go very fast for the adults. Normal play serves various purposes, and I remember when I became a child psychiatrist first, I was wondering why did they pay me to play with children. But thanks to Winnicott, you know, when a child plays in your presence, it's already gaining many things. And I will tell you, problem solving, cognitive functions. It has been seen that children who play are more creative and more persistent in solving problems. So there is a cognitive positive factor about play. It deals with aggression and regulation of affects. It masters anxiety by turning passive into active. The child tries new skills. There is a channel for creativity. The play serves for sublimation and identification. It's a wish fulfillment, like dreams are wish fulfillment. Establishes a sense of identity. And this is where we come back to the topic of identity. In children, the capacity to play reinforces the sense of initiative, cohesiveness, purpose, and oneself, so that there are levels of play. For example, the highest level of play is directorial play. And in English, the term play is very fortunate because it's theater play and the play of children. And a child who is talking with the therapist and discussing what's going to happen to the different roles, it is using self-reflective capacities, asserting his capacity to be and organize a scenario, so that the scenario of his internal world of self and object representation. So that's the inroad to assess identity in children. Develop self-esteem, the sense of accomplishment that children develop after they finish playing, and play is a means to develop social skills, because as children play, they interact with others. So that is a very important aspect of play. Play permits the child to learn about empathy with others. And what happens in sexual abuse is the next part of our... Let me give you some background about abuse, just to to have this the data in symptoms that have been found to be associated with sexual abuse are, in the acute stage, anxiety, sleep and eating disorders, depression, all kinds of symptoms, including some post-traumatic flashbacks, regressive behaviors. And after the acute stage, the aggressive behaviors become more likely to be expressed through acting out, as well as inappropriate and precocious sexual behaviors. This occurs in 46% of the variants. And I have to say that when we are talking about abuse, we are talking about a complex situation, because sexual abuse overlaps with physical abuse in around 56% of the cases, and with verbal abuse. So that we receive, it's rare to find only sexual abuse alone. Sexual abuse with emotional abuse is, I think, at least in my clinical experience, extremely common, and physical abuse as well. So, research findings from other people, 2/3 of sexually abused children meet criteria for one access, one disorder. 1/3 of sexually abused children do not express any overt symptoms. However, of the 2/3, around 30% will continue to show the initial symptoms, even deteriorate within an 18-month period following the abuse. The symptoms will seemingly disappear after 18 months in another 30%. The symptoms will re-emerge at pre-adolescence or adolescence, so there is a sleeper effect. In our opinion, none of these studies report likely effects of the trauma in the personality of the children, such as distrust, lack of the capacity for intimacy, sense of hopelessness, concreteness, suicidality, severe problems in peer relations, impulsive behaviors, sexualized interactions, dissociative states, and low achievement. As you see how much some of these symptoms are reminiscent of symptoms that you see in borderlines. And in fact, this is the first study that is a prospective study. So these children are being followed up to see which of these who we know have been sexually abused, what kind of problems do they develop later on. As you know, going retrospectively, a high percentage, more than 50% of adult borderlines, they talk about having been abused in one way or the other. So, about play as a way to assess sexual abuse. This points towards the necessity to use more complex methods of analyzing the impact of sexual abuse that do not only consider manifested behaviors and symptoms. The assessment of play may be such a method because it assesses the experience of the child from a cognitive, affective, and representational perspectives. Most important, because play is not under the influence of adults' prohibitions or threats. A child who cannot communicate verbally because of age and prohibition from the perpetrator may find it possible to freely convey his experience of the trauma through the language of play. How the abuse is experienced by the child, how is it processed, mentalized, and most of all, to which extent the abuse has affected self and other representations have to be addressed through approaches which are reliable and valid. Main critiques about the usual methods of assessing sexual abuse. The non-suggestive interview is directed towards the child to specify verbally who and how and where he was abused. This type of interview, even in the hands of skillful clinicians, may not be informative, as the child most likely is under the threat of not divulging any information. Moreover, the interview re-traumatizes the child by having him reveal his experience and making him betray the perpetrator. Information gathered from parents, either through interviews or questionnaires, are often non-informative because of parents' denial or bias in the case of suspecting or blaming the other parent of sexual abuse. This was also studied at Hampstead, and I forget the name of the person who reported this, but he described that up to 80% of children do get in contact with an adult to let them know that they have been abused, and the adults, most of the adults don't believe them. So he quoted, for example, a teacher who said to this child, "God bless you, forget about it." And they don't, they are themselves so impacted that children don't get the help they need. Now, the other aspect of play that I would like to add is that you cannot tell a child what to play. It's impossible. It's a spontaneous activity, so that this is another reason why play becomes then more valid if it tells you something about sexual abuse. Well, what we found here is a series of characteristics, and we have been able to glean these characteristics studying the videotaped sessions of play of children. So the play of children who have been sexually abused, plus in addition to the traumatic play, we added the following characteristics. The compulsive repetitiveness was certainly there. The documentary quality, we found like a documentary film, as I mentioned, compared to a regular film. The play disruption, an abrupt disorganization of the play activity due to a flashback of the affects, thoughts, and memories linked to the abuse. For example, a child stops playing and even hides under the table as a father and a baby doll start interacting with each other, in contrast to the presence of satiation in normal play. So the play narrative is abruptly disrupted. Sometimes it is disrupted by hyper-alertness. What's there? What happens? So the child is always anticipating something to happen to him. The child follows a ready-made script, in contrast to the creative moment-to-moment development of the narrative of a normal play. We have a 3-year, 1 month old, the youngest of the group, who was sexually abused by the janitor in her care center, and the janitor had anal intercourse with this little girl, and she played exactly what had happened through a baby doll, and she was very interested that it had to be exactly as she planned. Introducing a thermometer into the vagina, poking the vagina with a thermometer, trying to get the opening of the thermometer because it didn't open, and she was very upset that it didn't open like the tip of the penis did. And then she started to wash this baby and answer to the interviewer that she was cleaning the blood of the body, and she was extremely meticulous. So you don't have to be a psychoanalyst to think that she's replaying what she experienced. So the next characteristic, no evidence of anxiety reduction, conflict resolution, mastery of traumatic issues. The play is a re-traumatizing play. The child under the influence of the traumatic is under the influence of the traumatic experience. There is a paralysis of his capacities to extricate himself from the specific role in the play. He sticks rigidly to the role of victim or victimizer. This is a very interesting characteristic because you see the child, once they begin to play replay the trauma, they cannot, they feel entrapped by it. And very similar to the fact that they cannot run away, they are under the coercion of the perpetrator. Apprehensions, which prevents a real, total, and satisfactory investment in the play activity. There is a constant hypervigilance, incapable to free himself from the fear of reenactment of the abuse. The child cannot easily immerse himself into the play, and I want you to remember what I'm going to read now. He's tending to start and stop his play so that he can be perceived as an attention deficit hyperactivity disorder. It was published in the American Journal of the Academy of Child Psychiatry, and I think it's very important if you have a child going from one thing to the next to rule out sexual or physical abuse. Spurts of aggression, a blurring of quality between fantasy and reality. The child questions whether the characters or narrative of the play are real or not. This is very unusual because when a child is playing, everything is make-believe. It is very rare that a child who has not been abused will say, is this real or not? And we have in one of the children, the same little girl that I was mentioning to you, was pressing the bulb of the sphygmomanometer, and she presses and you hear it. And then she says, do you hear it, to the adult? And the adult says, yeah, I hear it. And then she says, I hear it. And then she smiled and said, I don't hear it. And you see the sequence of being unclear whether this event happened or not. And in this video, you are witness that you heard it. You saw that the child said, I heard it. And that the adult said, I heard it. And then she says, I didn't hear it. So a sequence. What I want to mention here, because when these cases go into the legal arena, you believe then that the child has said it's not true and you forget about it. But it's the sequence of affirming and taking back, which is the total sequence and makes you suspicious of the possibility of this dissociative state that accounts for would it happen or didn't happen, what you see with adult patients as well. Incongruence of the play setting. We call this that way because there are scenes that don't make sense. The daddy and child dolls are having lunch on top of the toilet in the dollhouse. Why would a little 4-year-old think of having lunch on the top of the toilet? So the incongruence of this is also another quality. Drawings are designs, scribbles, and frozen static figures. Affix, this is, if you forget everything else I have said, you can remember this, are characteristically negative, in the negative range, from sober to outright crying during the play. The content of the play includes sexualized scenes emphasizing nakedness and body damage. In fact, in the findings of our research, body damage is number 1. Second, sexualized scenes. The obsessive compulsive defenses increase, cleanliness, orderliness, sorting out, and appear at 8 earlier stages, like this same 3-year-old that I am mentioning to you. She looked like a compulsive, obsessive neurotic. She was cleaning meticulously, putting things in an organized way as a way to coping with her anxiety. Identification with the victim and the perpetrator, both. This is a general statement for all ages. that the person will replay both, I'm glad that it's not me, identification with the victim and the perpetrator. Exclusion or minimal interaction with the adult, that's also typical and understandable. Dramatic impact on the viewer. The play is reacted by the clinician with denial or minimization. When I mentioned to you about this little girl poking the thermometer into the vagina of the baby doll, at some point the clinician asked her, "Were you taking the temperature of the child?" So an example of minimization, although this clinician was a very good clinician and was research doing, she knew that all the children that were coming were sexually abused, but this had such an impact on her to hear the child saying that she was cleaning the blood of the abdomen of the child that she had to minimize it. No eye contact, stilted and self-conscious behavior in body gestures, that's very clearly seen, especially in school-age children. Brief altered state of conscience, you can see dissociation, that's, this is all seen from the videos that we have. Frequent initiation of play activity and frequent interruptions with hyper-alertness. Presence of fragments of experience of abuse in the play, sounds, for example, scenes of body damage, and also, last but not least, secrecy in words or action. Tendency to hide behind a screen or a tent, or just say to the clinician, "Shh, don't say anything about this." So these are the clinical findings that we saw, and now we are going to look at the research. There are more, but I think I have mentioned the most important. So in our research, we try to propose that the analysis of the child's free play could be a method to study the phenomena empirically, to present some characteristics of free play that are of particular interest for the study of children's internal world, especially sexual trauma, and to compare free play of sexual abused children with non-abused children using this is the instrument that we developed, the child play therapy instrument, which is nothing else than what we do all the time, but we put it in an organized manner. And I will give you an overview of that to explore clinical and research implications. So what we did was to put 30 children equally divided into two groups and paired according to sex and age. Mean age 8 years, 2 months. The first group showed evidence, strong evidence, if not certainty, of sexual abuse based on a careful analysis of medical, psychological, social, and legal assessments. Children have been referred within 3 months after the abuse. They are equally distributed between intra and extra-family abuse. The second group is a comparison group with no evidence or history of sexual abuse. Children were selected from a larger study with a sample size of 190, now it's 250, referred with suspected sexual abuse, and a control group of 60 children. Children are instructed to play freely with standard toys displayed in a regular playroom in the presence of a therapist. We didn't want to encourage or induce any suggestions, so we have the standard equipment that any child therapist has. 2 independent raters analyze the material that has been videotaped. And here is the instrument, so I will go just to show it. What we did was to look at the videotape, and it happens that during the course of an hour, a child is not playing all the time. That's other things. So we segmented the session into play and non-play segments. So this is the segmentation. And here, then we did a dimensional analysis of the play, and then a sequential analysis of play session. We are going to concentrate on these two for the purposes of this presentation. The segmentation of the child activity. Types of duration of the child's activity. We found that there were non-play activities, preparation to play, pre-play activities, play activity proper, and then the play ending. Now, all of this is part of a manual, and you get training on. In 30 hours, you are ready to use the instrument. 20 hours for expert clinicians. We have done this in various places. Play ending was important, and the play ending could be satiation, normal, or suspension, normal, because what we found in the videotapes is that sometimes the child is playing and then leaves the play to look around or say a few words to the therapist and comes back and reinitiates the play. Very much like a child at the breast that can be sucking and then looks around and then comes back to the breast. So that's the quality of it. So this we only found in the normal group. Interruptions and disruptions. The disruptions consist certainly in an interruption plus a disorganization of the play scene. So it's a worse form of disruption. And the dimensional analysis of the play, affective components, we already talked about this in terms of the affect modulation and affect expressed during the play, cognitive components of the play activity, which gives us a representation of the internal world of the child, role representation, use of the play object, dynamic components of the play activity, setting of the play, where it happens, the themes of the play, quality of relationships within the play, the roles of the play. This is we extrapolated from the Rorschach test. That is, the relationship between the roles is a measure of aggression. There are two dolls that are having tea, to one role destroying the other, or an external diffuse force exterminating the scene. So it goes in a gradient of aggression. Development components of the play, psychosexual phase represented in the play, social level of the play, adaptive defensive function of play, normal, neurotic, borderline, psychotic. We could use the same criteria that we use for adults, looking at the narratives of the play, so that was possible also to assess mechanisms of defense in the play itself. Reliability results. Results indicate that independent raters reach good agreement after less than 40 hours of training. We have gotten to be better teachers, so now we can do it in 30 hours or 25 hours. In addition, raters reach good agreement on specific scales, like the type of child activity, duration of child activity, type of play ending. So it was reliable in all of these dimensions. The type of duration of the play activity. These are definitions. I will not go into to read them to you, but I will just highlight this one, which is the most important. How do we define that the child is playing? We thought it was obvious, but we had to express it in words. So this is the definition. The child becomes engrossed in playful activity, often preceded by the adult child exhibiting one or more of the following behaviors: an expression of intent, let's play, followed by play activity, actions indicating initiative, such as definition of roles, this dolly will be the teacher, verbally suggesting we can both climb the mountain, an expression of a specific positive or negative affects such as glee, delight, pleasure, surprise, anxiety, or fear. Focus, concentration with toy or person. Purposefully use of toy objects or physical surroundings. So you have a way of saying the child is playing, is in a play activity. Difference in frequency of each type of activities between abused and not abused children. The abused children are the green, and the non-abused children are the yellow column. And you can see here that the number of segments of the children who have been abused, they play significantly more, these are significant differences, than the children who are non-abused. And if they play more segments, there's more segments of play activity. That explains in this way what they found, that children who have been traumatized may be confused with attention deficit disorder because they go from one thing to the other. So we had here experimental confirmation that they have significant more moments of play activity. Difference in duration of each type of activities between abused and non-abused children. Here we see a big difference, the duration in minutes. Normal play, up to 10 minutes, this is duration in minutes, up to 10 minutes, and non-abused children, 6 minutes in the play activity. And we have used this instrument with children between 1 year to 2 years of age. A colleague in Uruguay has been doing research on these toddlers, early toddlers, and a normal 1 to 2 year old plays 10 minutes, just to give you, to our surprise. A child of that age can play that long, so it is particularly pathological that you will have shorter segments. The play ending. We talk about satiation, suspension, interruption, and disruptions. So we'll see what happens with the differences in these two groups. Here, again, the same thing is the yellows are the normals. Satiation, most likely to end in satiation, that is a satisfaction, normal ending. In contrast, the children have significantly more interruptions and disruptions. They either cease to play and they cease to play plus disorganizing the play scene significantly. These are differences PO1 for those who like statistics. Themes of the play. Here, abuse themes, body damage, sexual activity, destruction of the environment, death. Non-abuse themes, caregiving, soothing, cleaning, feeding, messing, resurrection. There is death, but the dead people come back to life. So here we see the themes. Here, abuse theme, non-abuse theme. Again, there is significant differences in that the abuse theme is the themes that are connected with abuse, particularly body damage and sexual activity, significantly higher. Now, what we found is that both groups play non-abuse theme, and you will ask me, what's the matter here? What we found indeed is that the children who have been sexually abused don't play sexually abused themes all the time. They play 50% of the time. But when they play, these are significantly higher, so that at times the child, especially if the child has had a normal, relatively normal childhood, they still can play normally or almost normally. Differences in the explicit quality of abuse themes between abused and non-abused children. Here we have the context. In the abused children, the greens, more sexual themes, more body damage themes, more even than sexual themes, destruction in both, and death in both. So that the most important differences were in sexual and body damage themes. Quality of the relationships in the play. This is what I mentioned to you that is extrapolated from the Rorschach. Autonomous relationship. The play characters are interacting freely. Parallel. The players are engaged in a parallel activity. There is no overt mutuality, no indication of a negative relationship. Dependent. Players are leaning or hanging on each other, or some of the play characters do not stand on their own 2 feet in some way. They require an external source for direction and support. This is a twinning. One of the players is a reflection or imprint of another, like Simon Says or Copy Me, that kind of game. Twinning. Then malevolent control. One player is in the clutches of another. Themes of influencing, controlling, and casting spells are present. Some characters are powerless or helpless, while the others are omnipotent and controlling. Destruction. The imbalance between players is definitely destructive. An attack on the physical and psychological integrity of one player by the other may occur through torture, strangling, or a parasitic relationship culminates in the diminution or destruction of the other. Annihilation, that's the worst one. The play activity is characterized by an overpowering, enveloping force. Players are swallowed up, devoured, or overwhelmed by forces completely out of their control, ending in total annihilation and physical destruction. So here the differences in quality were significantly different in the negative. There was practically no autonomous and no parallel play, but there was significant, and this is the important one, malevolent control, which is not hard to see that this is part of the experience of the child that cannot extricate and is under the influence of a sinister experience. Affects. The affects, as I mentioned today also in relation to identity and personality disorder, these are the criteria that we use for affects, and we'll see also what happens here in a graphic form. Negative affects, much more frequent in the abused child. The spectrum of affects restricted, the regulation of affects restricted, and the transition from one affect to the other extremely restricted. These are all significant differences. Conclusion. I didn't show you the video. I told you about the video. But this little 3-year and 1-old fulfills these characteristics of the traumatic experience of sexual abuse. Recapitulation of research findings. Significantly more play segments that makes them be confused with attention deficit disorder. Significant shorter play duration that goes together. Play ends significantly more in the form of disruption or interruption instead of satiation and suspension. Significant more malevolent control in the quality of object relations instead of parallel play. Significantly more body damage and sexualized themes. Significantly more neutral and negative affects. In spite of the small sample size at this moment, the study suggests that the CPTI is a good instrument to identify the signs of sexual abuse in young children and to assess change in treatment. Now, we have added two populations that are currently being analyzed, but I can advance them. One is to see how do children who are psychiatric inpatients, for example, play, who have not been sexually abused. And what we have seen is that this profile is not there, except that they have, if anything, more segments. They have up to 28 segments. And the themes are also of destruction, but there is more annihilation. There is not a completely different profile. Sexual themes are absent. Then when I presented this to a group of lawyers, he asked me that this would be really valid if we got a group of children who accuse the other parent of sexual abuse, but that was not warranted, was not proven in any level. So whether if these children played the same or not as this group of children who have been sexually abused, and we have collected that. I don't have it in the slide, but they don't play like sexually abused children. They say they have been abused, but when they say, and it is not true, the play cannot be, is not reflecting the accusation. So that's a negative that I thought it was a very good idea of this lawyer to suggest it, and it will be part of the, we were waiting for these two studies to, we haven't published this until we have the studies of validity, discriminant validity for psychiatric patients without abuse and falsely accusing children who don't play in this way. The CPTI is a reliable and valid instrument that needs, however, further sensitivity testing, and we have it by now. And we need, however, to still study the difference between erotized and sexually abused children, because that will be another interesting measure of how sensitive it is. Between physically and sexually abused children, you know, children who have been exclusively physically abused, it's not so easy to find pure culture, but this is further studies to do. Between non-sexually abused and sexually abused clinically referred children. So treatment, a specific treatment to sexually abused children is manualized based on these encouraging results, and we have developed a manual of 30 sessions with a psychoanalytically inspired approach, which is aimed at transforming traumatic play into normal play and transforming the traumatic experience into a memory of the experience. That is, the child should, at the end of this treatment, be able to talk about this as a memory, not as a reenactment of experience. And that is also going to be published within this year. So, well, I thank you for your extreme patience, and that's it.